All right. Welcome everyone back to another virtual shadowing session. We missed you for the Thanksgiving break. Hope y'all enjoyed your Thanksgiving. And I know y'all are ramping up for finals. So good luck to you for those who are still in undergrad. Best of luck with finals. But we're glad you could join us today. Take an hour for our virtual shadowing session. Today we're going to be joined to talk about preventative care as a PA. I know we have a lot of pre-PA students out there, so we are very excited to bring this forward to you. By the way, if you have any questions, and especially if you're new, we do have a Q&A at the end, so definitely feel free to pop them in the chat. That should be either on the right side or just below the video that you're watching right now. And like I said, it will be at the very end, so we'll go through those questions in the order that we receive them. And outside of that, not really much to be said about the actual session. It will be over preventive cardiology, but we have had other PA speakers. So if you would like to look through those, you're more than free to. We have our videos up indefinitely so that you can look back and take a listen if you didn't get the chance to. This live stream here will also be open afterwards. So if you'd like to look back, you're always more than free to. In terms of those who'd like to stay tuned with us for more shadowing sessions. So we do have two routes you can go about that. We have our Instagram page. And that's maybe where a lot of you have heard about this opportunity from, our flyer on our Instagram page or through our email outreach. So we have an Instagram page where we post flyers, and we also have an email listserv where we also include flyers, but also a few other opportunities. We've recently had a lot of applications for our volunteering programs, our mentorship program, our internship program. They recently have closed, but they were posted over our email listserv. And to get added onto our email listserv, you can either email us. Our email is shadowing.h4h@gmail.com. Let us know your name, your email, and that you have intent to join our listserv, and we'll manually add you on. Or you can go ahead onto our website. At the very bottom of each page on our website, we have a subscription form on the left-hand side. So fill that out and click submit. You'll be good to go to be added onto our email listserv. That's a weekly email, usually sometime between Sunday to Tuesday, that we will send it over, including flyers for the upcoming sessions that week. If you have any questions about that, let us know. You can always feel free to email us through the same address that I just provided, but I don't want to take up too much time, so feel free to take it away.
Okay, thanks. This is a wonderful program, and thank you. I'm honored to be invited to come aboard and discuss my work as a preventive cardiology PA, and probably more appropriate, as you can see in my title, I'm an associate professor of research. And so the preventive cardiology portion comes out of what I do as a clinician researcher. I thought it'd be a little fun to, of course, this meme, I don't know if folks have seen that before, but you're on a journey, so keep calm, perhaps not too calm and faint, but recognize that preventive cardiology is something that really it is a weird space, because you would think most medical providers try to do some type of prevention, and in fact, that's true. So as we move forward here, I attended PA school at the University of Utah master's program, and it's been a little bit of time. I'm hitting the front edge, I guess, of 20 years of having matriculated at the University of Utah program. So 18 years in practice, and I currently practice as an associate professor of research with Intermountain Health here in Salt Lake City, Utah, although now we've kind of expanded across 7 different states, most of them connecting contiguously with Utah. But I practice general cardiology about 1.5 days a week, and then preventive cardiology is something that we initiated and started about 2 years ago within our clinic. But it was a natural progression to what I do as a clinician researcher. I am also part-time faculty at the Rocky Mountain University of Health Professions. That's down in Provo, Utah. And so for those, Michael's told me that there's multiple pre-PA students on here. We now have a 4th program in Utah. So there's the University of Utah, which has a satellite program. So maybe 4.5 is more appropriate to say. We have the Utah Valley University PA program, which just recently received provisional accreditation. Rocky Mountain has been around since 2015. And then Weber State University just opened their PA program I guess didn't just open, but they received accreditation, and perhaps they've already done interviews and have their first cohort ready to go. But at the Rocky Mountain University, I'm a co-director of cardiology didactics, meaning I help develop the curriculum and teach a lot of the cardiology lectures there. I'm currently serving as president of the Academy of PAs in Cardiology, Physician Associates. We're a constituent organization of the American Academy of PAs. I'm also co-chair of the American College of Cardiology PA work group. That is a mainly physician-led organization, but it's become more and more advanced practice providers with our physician partners. And then I have multiple committee positions within several national cardiology organizations. And as you'll kind of see as I progress the slides, you'll think, well, why would you be a member of multiple national cardiology organizations? Well, I've only mentioned American College of Cardiology. There's the American Heart Association. There's the Heart Failure Society of America. There's the American Society of Nuclear Cardiology, American Society of Preventive Cardiology. So there's multiple different subspecialty organizations within cardiology. A little bit about me. Well, we'll journey together here, but I think this is apropos of really what this program is, and what Michael is in the Hearts for Health program is building is to understand what the journey is to move forward in the health profession. I love this quote by Lao Tzu. And for those that don't know, this is Bryce Canyon. It's the view from above in Utah. So please come and join me here after you become a certified PA or nurse practitioner or whatever. Come join me in Utah. But a journey of 1,000 miles begins with a single step. Guys and gals, it takes a little bit of time, but time goes by regardless of what you decide to do with it. So the journey, you're on it right now, regardless of whether you know where you're going. It can be meandering all over the place. And don't worry whether you're directly on the path or you're somewhere around, it meanders. Some people kind of take a pretty direct path, regardless of whether or not there's curriculum set forth or some type of organized path that's structured. We tend to do this. It's human nature to kind of find our own or forge our own way. So you just recognize that as you're moving through this process, whatever you decide as a health professional or what career, even if you decide not to go in the health professions, just recognize I have a lot of colleagues that later on down the road in their 40s and 50s decided to join the medical profession after a different journey than I had. So my own journey, just to kind of give you level set this a little bit. In high school, I was a skateboarder. I ran cross country and track. You can kind of see here me launching off of our little quarter ramp. And I wasn't the best student, but I kept a decent grade. And was in AP and honors. Yes, I served at Arby's. And so I can do a roast beef sandwich, a mean one. I was involved in multiple school clubs. I think that's important to get a feel of multiple different things and see what you like and what you don't like. But also was, in a leadership council with youth. That's actually me and my son side by side, 20 something years apart. And I'm on the right, he's on the left. But it's always interesting to see time fly by in what happens when you move on through your own journey. Oops, sorry, let's see here. So let me just kind of give you the lowdown a little bit when we're talking about PA versus MD. This is not to say that PAs are better than MDs or MDs are better than PA. We're separate professions. We are separate professions. There's not a PA to MD unless you're going to the Caribbean school of whatever. But here, we both start with bachelor's degrees. 3 to 4 years of bachelor's, and depending on the school you're applying to, you may actually have to have that degree in hand. Certainly, most PA schools, because they're master's level entry, you need a bachelor's degree. And then that graduate school program. Here's the PA school. I mean, it's 27 months and, it's a master's degree, 1 year didactic, 1 year clinical. Now, there are several programs that are moving into a doctorate level pathway as an entry. So you just enter as into your terminal degree as a doctorate. And then physician medical school is 4 years. So you're not a doctor yet. You're as a medical student, but they do have to pass the USMLE 1 and then 2 to get into this portion. Now, there's not a medical residency per se, at least not structured, and it's not mandated for PAs. There are several available. In fact, we're creating one at Intermountain, one specific for cardiology, but we have a primary care residency. Physicians, they have 3 up to 6 years, depending on the specialty, where they match, what they're going to do. If it's surgery, it can be quite a long haul. Then there's a fellowship. So again, PAs here don't often have we don't have anything mandated in terms of a fellowship, but we're also designing one too at Intermountain. So a residency and a fellowship. But here, physicians typically do complete fellowships into a specialty or a subspecialty. Now, in the end, you can see the total years. And there's, an obvious reason why, as a PA, I am tied to practice with my colleagues who are physicians. When you're looking at 5 to 6 years of full training and practicing as a PA, well, it's 10 to 17 years for my physician partners. And so that's a lot of time training. I would say that probably where PA's best fit after we graduate is right here. We're kind of eternal residents and maybe even eternal fellows. And that's really what I've been doing as a PA in cardiology is the past 10 years of full cardiology practice, 7 years of occupational medicine, and then 2 years prior to that in cardiology. These are different kind of residency, practice that I've done in the real world. So we're kind of eternal residents. So I just want you to know that whether you're 18, whether you're 20, whether you're 35, this is the road that it takes you in terms of if you go PA practice or training or physician training. But if you're 20, you're hoping that you'll get to 35 years of age. So my point being is that time will pass. Those 15 years, whether you're training to be a doctor or you just kind of wandering around. So don't be afraid to go the physician path. Now, the question that comes up a lot is physician assistant or physician associate. Well, let's talk about that. It has recently been changed because the American Academy of PAs had voted last year to change the profession's title to physician associate. So shortly thereafter, they rebranded, are now the American Academy of Physician Associates. We followed suit, and my term as president of the American Academy, the Academy of Physician Associates in Cardiology. That's what we changed our name to shortly after the AAPA did. But just know that once we actually did have the apostrophe S and were owned by our physician partners to a certain extent, being physician's assistant. So being the assistant of the physician. So here, I think it's a progression over 40 plus years of what our profession has done. Okay, so I'm wandering through this so that you get a good feel. Again, for those that are going the PA path, I just want you to know what's out there. There are numerous programs. This was from a talk I gave in 2021, looking at the different programs. At least one more is added onto here, but probably many more. So we're probably near 300 programs across the United States, and graduating somewhere around 10,000 into practice. So you can kind of see the provisional accreditation, the fully accredited, and then programs that are on probation. That happens. So you do have to be careful and hope that you really interview your program just as much as they're interviewing you. It's so important. We've seen this happen where students have been left basically hanging when their school goes on probation or loses their accreditation. Here, it's just, know that there's a certification and maintenance. Hey, medicine changes. We need to maintain our ability to be cutting edge and on the front edge of medicine. So this is just, for practice in the US, understanding what that certification means, PAC, and then what it means to maintain that certification and your ability to practice. And so 100 CME every 2 years. It's, not for the faint of heart, and certainly for those that are afraid to learn. Well, our physician partners are the same. We have 100 CME every 2 years, and that's hours of education. So scope of practice is very generalized. It just depends on the state that you're in. Really, you can see in that bottom corner there, and I don't know if you can see my mouse there, but probably not. But anyways, you have the federal. That's the overarching practice of certification. National Commission of PAs, NCCPA, helps to dictate some of that. So there's federal laws. And then there's state-specific laws of what we can do in terms of prescribing, diagnosing, imaging, seeing patients on our own. But within each of those states are hospital systems, and you can be accredited or privileged to do certain things within those hospitals. So it's really kind of goes from federal down into single group practice and where their hospitals are. But we're, broadly speaking, generalist trained. We're internal medicine, family practice, etc. Okay. Overall U.S. practice is really, again, delegated tasks agreed upon between a physician and the PA. There's supervised practice. PAs are providing patient care. They're usually doing the same tasks as their physician. You wouldn't practice cardiology under a radiologist, and you wouldn't, do radiology interventions under a dermatologist. So you have to practice similar to the physician that is collaborating or supervising you. So you can see the different things that we do here in terms of prescriptions, chart reviews, visits, etc. Now in Utah, this was the pre-2021 example. We did have a delegation of service agreement, but now we can practice with no specific physician relationship. So that changed last year. But that doesn't mean that insurance partners will reimburse me for practicing independently, or that hospitals will hire me as an independent PA. It's tied to an hour system in terms of practice. And then what you'll find is, as you go back to that first slide that I showed, PA compared to MDs, really what was built into the law was 4,000 hours, the first 2 years of practice, kind of like a residency. You're supervised specifically by physicians. And then from 4,000 to 10,000 hours, you can be supervised by a veteran PA. So someone that has achieved 10,000 hours already, or 5 years of practice. It looks like a residency plus a fellowship in terms of time out and practice. So that's kind of the thought process we had when we pushed that legislation in. You can kind of see the distribution of PAs throughout the United States, where they're more per capita here in California, and then heading this way. It just changes from state to state, and really, I would tell you that practice acts. State practice acts, whether they're independent or autonomous or very heavily collaborative, then you'll find less PAs in those places where there's less autonomy to actually do patient care. But okay, here we go. You came here to talk to a preventive cardiology PA, but I wanted you to kind of get a sense first of what you're stepping into if you're thinking of the PA profession. Here, cardiology, it's a specialty, right? Just you hear rheumatology, you hear dermatology, cardiology, etc. It's a specialty, but it has multiple subspecialties. So you can see here from a general adult cardiology at the top, just heading on down: pediatric, heart failure, cardiovascular, non-invasive imaging, interventional cardiology, which has subspecialties of peripheral intervention, structural heart. These are the stents, the valve stents that we place. Electrophysiology is starting to kind of branch out a little bit, but these are the folks that deal with palpitations, arrhythmias, pacemakers, etc. And then we have a two new subspecialties: cardio-oncology, because there's a lot of cancer drugs that will cause damage to the heart. And how do you manage these things? Cardio-obstetrics, pregnancy, there are a lot of cardiovascular events that occur around pregnancy. And then preventive cardiology, which is often paired with lipidology, as well as hypertension management, adult congenital, and then vascular medicine. So what we've done in my practice is really, first and foremost, I kind of started out as an adult cardiology PA back when I first came out of PA school in 2004. But I was paired to 13 different physicians who all, there was a general cardiologist, there was a non-invasive imager, there were interventional, and then EP. And so I actually practiced across 4 different specialties, subspecialties, as a single PA. And it was sometimes awkward, a little confusing sometimes, which attending I was working with at any one time with any specific patient in that subspecialty practice. So you can find yourself all over the place. Here I just, kind of a picture, top right is the echocardiogram and sonographer here doing that. Down below, of course, the beating heart GIF. And then you see a person just getting ready to do cardioversion. If you want to scare yourself, go ahead and not now, of course, since it's live stream, but in YouTube later, just look up cardioversion. And there's all sorts of recorded versions of how we shock folks into a normal rhythm. And that used to be one of my favorite activities, but I now mainly stay in outpatient practice. Here now you see this is the cath lab in the mid between the sonographer and the beating heart. That's where they place stents, right? You're in the cath lab and you have this big C-arm, which is an X-ray that does fluoroscopy. And then in the far left bottom is doing stress tests. And I still occasionally supervise stress tests, but typically our cardiac therapist will do that. So preventive cardiology, let me expand it a little bit for you. Just know that we always place patient as center. What do I mean by that? Look, we've all been to our own clinician, whether it's urgent care, emergency department, or our pediatric visits, get your awesome shots before school. And often things are just done to us, right? There's this certain license that we give our clinicians to just do things to us, whether it's sticking a stethoscope on us or doing a prostate exam, etc. And so it can be quite invasive to your personal space. I like to flip the switch here and flip the script, rather, that the patient is center, and really we're there for them. They are not there for us. So in general cardiology, preventive cardiology ends up being really a focus. It's a mashup of all the things general cardiology do. I manage heart failure. I manage arrhythmias in general cardiology. I manage blood pressure. I do a lot in terms of referrals to my interventional partners so that patients can get stents. I refer to my structural heart folks so that patients can get their valves replaced, or TAVR, which is transcatheter valves. But really, it's implementing more intensive therapies, doing a lot of what general cardiology does, but on a more intensive level. We're trying to get at how do we make sure they don't have another event, rather than just treating symptoms. We focus on, look, that heart attack, that was rough. Let's keep you from having another one if we can. That stroke, we don't want you to have another one. Or that heart attack leads to risk of stroke or peripheral arterial disease, etc. So we're doing a lot of intensive therapies, and then really inviting appropriate medical and community collaborators, right? Physical therapy. We're making sure we're discussing with primary care. If we have as a preventive cardiology practitioner, I can have my own patient panels, and I do for my general cardiology, but often I'm in a consult role. So I have my partners or colleagues send their patients to me, look at their charts, I review their current therapies, I intensify those therapies. I really look at how we can optimize so that we can reduce risk but keep benefit at a high level. And I spend a lot of time educating patients on their disease, a lot of time, because look, I've been, I went through 2 years of 27 months of PA training, but I've been at 18 months at this. And furthermore, I'm a researcher, so I know a lot of the different trials, how we come about the drugs, etc. Why would I expect a patient who's just suffered an event to know all of that all at once and all the different medications? I went to school for that. So there's no reason for us to just say, here's this blood pressure medication, just take it, call me in the morning. So I deliver a lot more in-depth education to the patient. And furthermore, I make sure that we expand it to their families, friends, their caregivers, their support network. So again, the patient as center, but as part of that center is really the people who are with them 365 days, 7 days a week, 24 hours a day. It's not me. I see them once, maybe, every couple of months. And for those that I return back to their cardiology practitioner, then I may not see them again. Everyone gets my cell phone though, so I get a lot of texts and calls from patients when they have questions, because they know I'm open to answering those and making sure that if they have family members that needed to hear it, weren't able to come to the visit, I'll take some time and explain it. But I like to explain the diseases, the therapies, and prognosis. To me, that's preventive cardiology, because if you don't know why you're taking something, then you probably will run out of it. You won't refill it because you think, well, Viet said I just needed it for this long. So as they're educated on what the disease is, what the prognosis, how it progresses, and then how the medications affect that, whether it prevents it or it's just symptomatic treatment, etc., then now I've put the patient in the driver's seat, and I'm really just I'm kind of like Google Maps, right? I'm just telling them where the best route is, and hopefully you choose it or you decide to go off the road and do your own path. But really, that's what I see myself as, is a very highly educated care navigator, and then the patient as pilot or center. So, and we'll talk a little bit more about that and what that means as preventive cardiology. But let me talk a little bit about clinical research, because that's first and foremost what I am. I'm an associate professor of clinical research. I am sub-investigator on multiple clinical trials, and actually have a couple of grants for my own investigator-initiated studies. The most recent one is peripheral arterial disease. So as a clinical researcher, though, I have access to investigative therapies. These are those that are not FDA approved. They're in phase 3. And all of these are placebo controlled. So it's a 50-50 chance that you'll get either what we think is therapeutic or a placebo controlled medication. Non-clinician researchers or non-clinical researchers, they don't have access to that. So I can identify patients who don't respond to the usual therapies that we have, and then invite them to enroll in the studies that we have available. But because I'm a researcher and have developed these contracts and have access to these studies, then I am at the site and able to help enroll patients into therapies they would not otherwise have access to. But because of that earlier experience in therapeutics and clinical research, often well before FDA approval, I'm able to help coach my colleagues into how to prescribe these, how to use them, what the experience is, because otherwise they're left to looking at an FDA package insert and maybe reading the study online at the New England Journal of Medicine or Journal of American Medical Association. But here they have someone that lived and breathed those 5 years in that clinical trial and have access and experience in those drugs. So the cool thing, though, in research is that now because you're trying to do something with those therapies. So there's a hole or there's a question that we have. There's a gap in our knowledge of medical therapies. And that's what we're trying to answer. And that's what we're looking at with these therapeutic agents is how do we plug the gap? Will it work? Because these are clinical trials. We don't know that they'll work. We think they will, but often many of my colleagues don't recognize that there may even be a gap in our ability to provide care. So it's kind of fun from that standpoint. You're always just slightly ahead of, well, maybe even years ahead, depending, because again, these clinical trials last anywhere from 1 to 5 years. Okay, so a day in the life of Viet as a clinical researcher. What does that look like? Well, first of all, I'm not a lab scientist. I don't do pipetting. I'm not, working. I have partners that do, but that's not what a clinical researcher does. That's just, no, you don't want me by the pipettes. I might break some tubes and stuff. But because research has to be designed appropriately, it's all in the design. And by the way, that's how they're FDA approved. So however the study was designed, including what you were trying to achieve, that's what it's FDA approved for. So if it's a lipid lowering drug in a certain population, that's what it'll be approved for, and that's who you prescribe it for. So it requires clinical knowledge, familiarity, not expert familiarity with statistical analyses, but a running knowledge of why we run certain statistical analysis and what it looks like when it's performed. And then understanding an application of therapeutics in a real world settings. So many meetings. That's the day in the life of it. Today was a research day, and I was kind of clearing up parts of my clinical day on Tuesday, but a lot of meetings with folks. So I meet with pharmaceutical medical science liaisons, MSLs, we call them. They're not the reps. They're not the pharmaceutical reps who are marketing and folks, I mean, to be vulgar, they think that these people are peddling the medications, but really they're just there to help facilitate therapies. But the medical science liaisons are the ones that we usually work with to collaborate and develop research partnerships. Also collaborators and colleagues from other institutions like Mayo and Cleveland, Duke, etc. And then I meet with my own study team members. All three of these things happened today. I met with an MSL, I met with other collaborators, and then my study coordinators and my fellow principal investigators, as well as regulatory staff and data analysts. But during a day like this, again, this happened today too. I was studying patient charts that are forwarded to me from the study coordinators across 120 different studies. Is what we have in our cardiovascular portfolio. But I'm probably involved in 5 current enrolling clinical trials, and then about another 15 registries that we have going on at Intermountain right now. And at any time, we're looking at bringing in new studies. I meet with non-research clinical colleagues. So these are the general cardiology folks in the building next door or in the hospital. And I follow up with them. Hey, we're actually enrolling and seeing their patients. So I have a dual role as a clinical consultant in preventive cardiology, but also as a researcher or an associate professor of research. And then also today, plan, write, contribute abstracts and publications for submission to medical journals. So we just got back from American Heart Association Chicago in November. Where we had 11 abstracts. I was co-author on 8 of them, and then just learned today that I have 2 of my abstracts that were accepted to the American College of Cardiology in March. And several of my partners that, again, we work together. So they're co-authors on mine, I'm co-authors on theirs. So we have about 8 that were accepted today. But the day in the life of a preventive cardiology PA, what happened here? Well, I'm 100% full-time as a researcher, but because of my unique position, I actually just started practicing in our clinic with some of my physician colleagues, and we developed, we have a general cardiology half-day clinic, but the preventive cardiology, Jeff Anderson and I developed this about 2.5 years ago. So it's 1 half-day clinic a week, but we see the patient. This is fun stuff. I mean, it's when you say fun in medicine, it's not often that fun for the patient because they have the disease. But as someone that loves to think about medicine, I'm no Dr. House by any means, but we love the complicated cases because we feel like we have a way to help them and do things that really will change their lives. So we see the complex disease states. These require more intensive review of their charts, their patient history, again, in-depth education, because many of them, they got to where they were after 10, 15 years of being with regular providers who they may or may not have understood their disease. It's always surprising to me when I show them what a coronary artery is, and I show them where their stents were placed or where the bypass, and they go, wow, I didn't even know what happened the first time I had a bypass, let alone the second one 6 years later. And so it's kind of fun to be able to educate them about that. And then the medications. Many of my patients have strong family histories of just badness, early death, or early heart attacks. So for example, here, parent or the sibling with a heart attack in their 30s. I mean, I'm beyond my 30s now, but some of you, in a decade, you're there. Imagine just life ending at 30. That's scary. And so when it happens in a sibling or a parent, these are folks that are anxious. They need answers, and we're trying to do our best to make sure that we optimize their life and their lifespan so that they don't experience those early events. So I see these patients either with Dr. Anderson or sometimes by myself. We have our schedule together, and then often then he has his own off the side and I have my own off the side. So we'll kind of come together and see some of the patients in our regular lipid schedule, and then off to the side for any consultants or follow-ups that we have on our own. So then the question is, do we do this inpatient or we do this outpatient? I'm always happy that Intermountain has these older pictures of me so that I look much younger, although blurry. So who knows? I could be 80 in those pictures. Certainly I'm not in the inpatient picture there, but I've done both. Since coming back to Intermountain in 2012. I did a lot of inpatient work, and I did a lot of inpatient work when I first came out of PA school. But really at this point, because of the time commitments that I have, I am outpatient 100%, unless one of my patients happens to be hospitalized, which is very rare. It's been maybe once a year. A couple of them have been readmitted a couple times, but I love inpatient and outpatient medicine, but they're totally different. They have totally different paradigms and philosophies. For outpatient, I don't want my patient to go and be hospitalized. I'm doing my best to keep them out of the hospital. When I'm in hospital, most of the philosophy is stabilize, get them back out to their outpatient practitioner. So there's not a lot of, I shouldn't say there's not a lot of thought, because it feels like I'm denigrating my partners, but their philosophy is different. They're managing acute disease. They're hoping the patient doesn't crash, doesn't die while in the hospital. So you're just stabilizing things, and then you're trying to get them a leg up so that they can be sent back out to their homes. And hopefully the community then picks up the slack there. So it's very different paradigms of thought. But I would say if you do practice, once you become PAs or nurse practitioners or physicians, get a feel for both of them, because it's really good for your patients that how that circle goes when patients are admitted, they're seen on the hospital, and then discharged. It's very helpful. Let me come to this back to preventive cardiology. I'm kind of going back and forth, but I wanted to intersperse this with some ideas and some thoughts. So this is one of the reasons, actually, this is the disease that brought me to do preventive cardiology. I've since kind of expanded on this, but familial hypercholesterolemia is a specific genetic disease. It's the most common cardiovascular disease or genetic disease, excuse me. And so what is it? Well, these are people who have, so this is nice, right? FH, familial hypercholesterolemia. And you remember F is family. So a family history of early events. And then hypercholesterolemia is cholesterol, high cholesterol. And these are really high. They're not just kind of, well, maybe it was I ate a burger. This is genetically high LDL cholesterol. And why is this a problem? Well, these folks have events. They have events, but they also show up with clinical signs like this. You can see the ankle there. That's actually thickening from cholesterol deposits in the tendon. And then the middle picture there, that xanthelasmas, those are those little lipid deposits that sit in the eyebrow. And then in that upper lid area, they'll show up also below. You can't miss them. And when you see them, you should say, oh, maybe you should go see Viet. Here on the far right is corneal arcus. We used to call this arcus senilis, right? That it was common in old age. And you can see it in older adults. But this corneal arcus is this white rim that occurs around the cornea. That's lipids. Those are lipid deposits that occur there. Not everyone with FH shows up with that. Typically, here again, LDL cholesterol is a 190. Those are folks that are in the 200 and 300 range for their cholesterol. It's just like that skim of cream on top of something you refrigerated that was oily. So coming to this, familial hypercholesterolemia. Why is this so scary? Well, in a general population of males, at 50, the rate of events is about 6%. So of all males, right at the age of 50, it's 6% of them have an event. But in FH, 1 in 2, 50% of them, if they're untreated, can have a heart attack, a stroke, peripheral arterial disease, or sudden cardiac death. You can't recover from a sudden cardiac death because you're dead. So, and unfortunately, that's often the presenting symptom is death. In women, at 60, the usual event rate is about 6% or 5% in this case. It's 1 in 3, 30% of women under the age of 60 will have a heart attack or a stroke. And it's not just at 59, folks. This is like in your 20s and 30s. This was why for me, it's such it's a tough disease when it's not discovered until someone has an event. And for the first part of our preventive cardiology clinic, that's what we were seeing, were people who just were missed. They showed up with a heart attack at the age of 30. People said, well, yeah, okay, it's kind of weird, but we'll just treat you like normal. And lo and behold, they have this family history of events. You'd say, well, gosh, they already had their event. But what about their kids? What about their siblings? What about their cousins? If they have this genetic mutation, you have the potential now to find the highest risk individuals and impact the course of their lives. And so that's what that's what brought us to developing the Preventive Cardiology Clinic. So let's run through a case. This is always interesting, right? And ignore the primary risk reduction thing. This was part of a talk I gave. So I give a lipid talk and talk about medications, etc. But I thought this would be an interesting one for you. So here we have this 42-year-old male with no history of diabetes. So we often think of diabetes as a risk factor. He doesn't smoke. Again, smoking is a risk factor. And he's 42, so he's young. You might not think so, but I think he's young. Blood pressure is 120/80. That means his blood pressure is essentially normal. It's kind of knocking at the door of elevated blood pressure, if I'm being honest, to the recent guidelines. But his father suffered a heart attack at the age of 45. So here he is. He's like, dude, I'm 42. My dad had a heart attack just 3 years from now with my age. He was 45. So what do I do? What's going on? How do I prevent myself from having an event? So he was asking the right questions, and the right thing prompted him. And unfortunately, that's 42 years of probably having high cholesterol. So we look at this. His total cholesterol is 300. That's high. Greater than 200 is high. LDL cholesterol is 205. That's high. Physiologic normal is like 30. But most of us here, probably on this webinar and myself included, have cholesterols. In the US, we have them a little higher, probably 120, 130, but not 205. His HDL looks good. It's kind of high. Triglycerides are 150. So he kind of falls into this criteria. For me, this is bread and butter. This is a preventive cardiology patient who has a family history that's really strong, no other risk factors, but his LDL cholesterol is greater than or equal to 190. And I think to myself, he needs to be treated. And that's what the guidelines say as well. But people forget this as they're out in practice. So we place him on a high intensity statin. Of course, he didn't have any xanthelasmas, no ARCUS or anything like that. But boy, you can't just shudder a little bit that his dad had a heart attack at 45. He's 42. So I definitely want to be an intensive and really intentional about treating him. And a statin is first line therapy. Now you'd say, well, Viet, why don't you talk about healthy lifestyle and making sure he's exercising and diet, etc. No, those are all well and good, and those are first line. You talk about those, but I will tell you that this cholesterol is not related to lifestyle. It's a genetic mutation. So those things I tell people, please eat a healthy diet, exercise because it feels good. Do it because it improves your quality of life, it improves your outlook, and the gravy is that it helps your heart. But I don't want you to focus on it as this thing that I'm prescribing because you have to do it. It's because it just makes you feel better. Your quality of life is better. But the statin is something that needs to occur here. So the other part is there's goals of therapy. We need to get his cholesterol lower. And the guidelines tell us it should be at least less than 100. With the first therapy, it was 103. And so we add another medication called ezetimibe to drop it to 82. Now, in my preventive cardiology clinic, I really don't let this slide. We actually dig in a little bit deeper with this patient. We do other labs. Often I do what's called a coronary calcium scan and see if he has already developed plaque in his coronary arteries. And if so, he has coronary disease. He's just not had an event, but he has atherosclerosis if the coronary calcium scan is positive. In that case, then we typically add another medication to drop that cholesterol even further down to 40. So, this was the question: what genetic related disorder do you suspect? Well, hopefully I haven't left anything a mystery here, but we should suspect familial hypercholesterolemia in this patient. Now, kind of coming backwards a little bit, right? What about those patients that have diabetes? Is there something that tickles the back of our mind that they're at risk? And so here we have a 45-year-old Black female, African-American female with type 2 diabetes. Otherwise, she's healthy. She's not smoking. There's no family history of early coronary disease. She's not had hypertension that she knows of, but she happens to be on a medication that is an antihypertensive. It's a blood pressure medication for kidney protection. That's what renal is. And so, her blood pressure is 125 or 80, and her heart rate's 68. But, you look at that cholesterol and you're like, well, it's not high, but we also know that cholesterol is it's the backbone of plaque development. So the guidelines agree with us that with this diabetes, we really should just treat her to reduce her risk as much as possible. Because the news here is that while heart attacks and strokes occur in the general population, you already saw that at age 50, 6% of that of the general population can have a heart attack that are males. For women, at the age of 60, it's about 5% in the general population. But of all people with diabetes, 30% of them will suffer some type of stroke or heart attack or peripheral arterial disease. So this is a high-risk group, and it makes sense to just treat them. So I've said this term, primary prevention, secondary prevention, and I just want you to know these are two different roads, because secondary prevention means they've had a heart attack or a stroke or peripheral arterial disease. We're trying to prevent a second one. So that's what secondary prevention means. For primary prevention, we're trying to keep them from having their first event. And so that would be this gal here who has diabetes, and we're trying to make sure that she doesn't have a first-time event. So she would fall into this group called primary prevention. I just kind of want to give you a flavor of how we look at this, but these are the cohorts for statin eligibility. Statin is the cholesterol lowering medications, and those in green, these are the groups, right? So under the primary risk, it's diabetes 1 and 2. Anyone that's 40 to 75 years of age, that's me, I fall in that group. I'm on the lower end, not towards 75. I've not had a heart attack. I don't have diabetes. And so I kind of fall into that calculation there. And then, of course, our first case, our 42-year-old male, who had a cholesterol of greater than 190, it was 205. He would have fallen into this group. And then the secondary risk, and you kind of see where those are. So in secondary prevention, just as a, something to help you understand this, it's really acute coronary syndrome, right? Plaque that's developed in the heart. It's either ruptured or it's corking off blood flow. So a heart attack or a myocardial infarction, acute coronary syndrome. Then you have strokes, the type that have plaque rupture, not, an embolus or a clot that's gone up there, but this is a rupture of plaque. And then lastly, in the legs. And of course, this could be any artery here in the leg or in the body, but I, showed it as bigger because the arteries in the legs are bigger. But those are what constitute a secondary prevention, is people who have experienced any one of those three: a brain attack, a heart attack, or legs where plaque is developed. So again, there are cohorts for statin eligibility. These are the heart attacks, the stroke and leg folks. So again, as a reminder, here's primary risk. We definitely will treat type 1 and type 2. LDL cholesterol is greater than 190. Folks like myself, then we do this risk calculation to identify what the deal is. So coming back to our gal here, really this is where she falls, is she's between 40 and 75 years of age, diabetes. Missed is really the intensity of therapy, moderate intensity statin therapy. And then this is what happens, when you put her on this therapy, we'll reduce her cholesterol between 30 and 49%. Those are the types of medications you can use. And this is typically what will happen, is cholesterol will lower between these two frames here. Here, just taking another person that's 40 to 75 years of age. She's 60, but no diabetes, doesn't smoke, and really no history of needing therapy for her cholesterol. Blood pressure is kind of a little bit elevated, but she has this family history of an aunt with a heart attack. That's MI, myocardial infarction, at the age of 55. So kind of early, and she's 5 years beyond that. So she's like, oh, geez, what do I do? Is there anything I need to do? And, you calculate her risk. She's already on blood pressure medications. That LDL cholesterol, you notice I haven't changed the lab values here, because it could be anyone that has these values. But whoops, I guess this is the calculator, by the way. So you take the age, you're taking their sex here, the race, putting in blood pressures, etc. And then I'll just forward through that here. But ultimately, we calculated her risk to be between 5 and 7.5%, which you can put them on therapy. You can decide not to. I think she came to us with some fears with regards to this aunt with a heart attack at the age of 55. So I'd be comfortable in saying, well, she's, has risk, so we'll place her on a statin, and this is what you would hope to achieve on that moderate intensity statin. This next gentleman here, he's 57. He's smoking, but no history of diabetes. No one's ever treated him for cholesterol before. He's got this blood pressure 130/90, and he's on some medications. Here, I've changed the LDL cholesterol a little bit because, boy, the last two were 120. Here's 108. We're like, wow, he's almost at goal. But really what happens is when you calculate his risk, he's at an event rate of nearly 20% over the next 2 years. In fact, it's 23.4%. And what you find is it's smoking. The smoking is really what elevates his risk. If we were to go back and change this parameter in the calculator, it would drop at about 6% in his risk if you made him a never smoker versus a current smoker here. So because he's at high risk, then we place him on a statin, and that LDL cholesterol, if we cut it in half, which is really what typically happens, he'll probably be around 54 milligrams per deciliter, and he's right in range then with just a medication. But these are the things we have to think about, and I wouldn't just do this to him. I'm going to explain what the risk is, why we think the medication is important, and ultimately it's his decision. If he decides not to be on the medication, I'm not going to judge him, but I do want him to make sure he understands the data that I know. I don't want to prolong the presentation part. That was the end slide, by the way. So hopefully you've gotten a taste of what clinical research looks like from me, and what a preventive cardiology PA does. I'll open it up to questions at this point, if that's all right.
Well, first of all, thank you so much, Viet, for this presentation. It was very, very thorough. And like I said, not a specialty we've seen within our PA sessions so far, but we do have a lot of pre-PAs who are always excited to see PA speakers. So my first question here is, did you ever consider, in your own personal experience, becoming an MD or a nurse practitioner, a field outside of PA?
Oh, that's a great question. Well, I would say, let me answer the nurse practitioner part first. It wouldn't make sense actually to go NP. It's a fully lateral move, because our professions are treated very similarly. Now, we don't train the same way. That, NPs, let's just be clear, NPs come from nursing. You have to have some type of RN before you go to nurse practitioner. I've never been an RN, so I wouldn't be able to do that. In fact, I'd have to walk backwards and get an RN before I could become a nurse practitioner, just basically to do the same thing I already do. That's what my NP partners and I do, almost exactly the same thing at Intermountain. Now, with regards to physician, no way. Not after 18 years of practicing the way I have. I've developed my PA career and my profession how I want to practice. And there's nothing that an MD now, 18 years later into my life, would afford me over what I already do and enjoy. I'm a consultant, so my physician partners consult me. I get texts all the time from my physician partners. What do I do with this? How do I do? Hey, can I send a patient over to you? Because and it's not to say that I think MDs are inferior to me. They're not. It's just I have found my stride as a PA, and I feel very comfortable with what I do. I recognize where my guardrails are, and I'm not going to overstep those. I love my physician partners, and there's just really no reason for me at this point. Had you asked that question maybe 15 years ago, I might have entertained it. A, because I was younger, but B, I hadn't established my career as maturely as I have.
And to tag along with that, you mentioned like getting into your stride. You talked about being a clinical researcher and also a consultant.
Yeah.
With that said, how did you go about developing your way around adding clinical research as a significant part of your day-to-day life? We haven't had any PA speakers, I believe, so far that have discussed something like that. And for those who might be interested, how can they get started on that shift that otherwise would not be the case for people who just pursue practice?
Yeah, we're not set up for it in our PA professions. Nurse practitioners are a little bit better suited for it, partly because their training has a lot of hours that they are able to pursue other academic interests beyond their training. As a PA, I was in the seat my didactic year where I'm learning 8 in the morning to 5 in the evening, and it was 40 hours. There was no way I was going to add anything extra beyond the clinical teaching. My clinical year was just basically 60 to 80 hours of clinical work in training. So coming to this, how did I get here? It was purely by accident. I feel like if you haven't seen Forrest Gump, do so, because it really gives you a great idea of what happened between the 60s and the 90s. But the other part of this is I was just found myself in interesting situations as a PA. I kind of happened onto being a researcher. When I returned to Intermountain, actually, I wasn't ever an Intermountain employee as a PA. I was a cardiac therapist at one point. But as a PA coming to Intermountain in cardiology, I was hired as a research PA with no experience whatsoever. So it was like this serendipitous moment. And to be truly honest with you, the reason why I took it was because Intermountain had a policy that if I stayed in a position for 6 months, I could slide laterally into another position in Intermountain. I wanted my foot in the door. Now, that doesn't mean I didn't give 110% with doing research, because I don't know what this is. Let's just do this. By week 2, I knew I had a home. A lot of it was my clinician or physician research partners, Jeff Anderson, Brent Muhlstein at the time, who really made me feel at home and made me feel like a colleague. They just threw me into it. I had to do city training, which is a specific research training. I had to learn how to do study design, but they had already put me in the IRB as a sub-investigator on one of his studies. And talk about drinking from a fire hose. I thought PA school was tough. It was quite a great lesson, actually, but because they made it so fun, it wasn't boring. And maybe it's because I'm just a nerd. I don't know. I know that sounds derogatory to say nerd, but I carry it proudly. I love learning these things. So really, it was by happenstance that there was one of the first positions. Actually, I'm the only PA in research, only advanced practice provider that's a full-time researcher at Intermountain. We have 65,000 employees. I'm the one clinical research PA that's full-time. And it's just weird how it happened. Now, having done this, I can see it happening in other places, partly because pharmaceutical companies have been really open. They realize that advanced practice providers, nurse practitioners and PAs, we prescribe 40% of all prescriptions in the United States. That's a huge power that we yield and wield. And pharmaceutical companies recognize, maybe we should employ nurse practitioners and PAs because they're the ones that can talk to their PA and nurse practitioner colleagues about the medications. So there are a lot of positions opening up actually in the present day. So by the time folks here go through NP or PA school, you're going to find there's a lot of research opportunities that weren't there before. So many of us have kind of pioneered that and opened the door. I've got 4 PAs that I can that are good friends of mine that are MSLs, medical science liaisons, and that position didn't exist like even 3 years ago. So it's cool from that perspective. Now, if you want to be a clinical researcher like me, I would say get your feet wet. There's a lot like Mayo and Cleveland kind of mandate some clinical research by their providers, meaning you don't actually have to be an investigator, research investigator, but you are seeing study patients, you're helping do things. You don't lean into that, leverage that, because it's a chance for you to read about the studies that you're enrolling patients into or you're doing physical exams for, etc. If your center or your institution has that, ask and say, hey, how can I be a part of that? I have 2 or 3 PA colleagues right now that are doing that just on the periphery, and they're learning more and more instead of like both feet in. They're getting a sense of it by working with me. And I often reach out and try to get my colleagues involved. So, so that's part of it too. Find someone that will mentor you, but it's there. The research opportunities are there.
Well, that's definitely it's very empowering to know, definitely for those who are listening in, because it shows how much the field is growing. A lot of these positions, like you mentioned, were not opened up just a few years ago, when they are opening up. So definitely an evolution to the field, which is always great to see. Yeah. And maybe we can just end it off on one more question. Looking back, I'm not sure how many years ago, but it might have been a while since undergrad. What kind of extracurriculars do you take? What kind of classes do you take that now with all those experience, with all that experience, now in hindsight, do you believe prepared you most as a PA today?
Oh my gosh, guys. So what a great question. So let me tell you, as a PA faculty member who lectures at the PA program, who helps with admissions, and then also teaches webinars for my colleagues who are already professionals. We can teach you the science. You can learn the science. I know, some of you are thinking, oh, I don't know math, I don't know chemistry. You can learn it, I promise you. What you can't learn is the soft skills. And you can't learn those by doing hard sciences. You can't learn those accidentally. You have to put yourself into situations where you're going to learn soft skills. And if that means not because you want to pad your resume, but because you truly love humanity, go serve, go volunteer. Folks here will hot take. I like the humanities courses. And the reason why they're called humanities is because you learn about humans. Art is a way to learn how people express themselves, the range of expressiveness. Take an art class, learn how to express yourself, because it's those moments that come up in a conversation with the patient, like, hey, yeah, I took black and white photography. And they're like, well, I do photography. And you make a connection. And then you could talk about them as a human, not as a disease. So let me just, my undergrad was exercise science. I did an exercise physiology, was my bachelor's degree. But I also was an athletic trainer. So I I entered an AT program my senior year. So I extended another 2 years thinking I'd be a physical therapist. But I was a certified athletic trainer, head athletic trainer at a local high school here, when I realized, I'm being paid like $1 an hour while working almost 100 hours a week. So, but what fun. I learned to really get the sense of how kids think. I even taught at the high school that year, and that was great. I mean, those are the kind of experiences that lend to having a lot of empathy and the ability to kind of put yourself in the shoes of a patient. I can teach you science. I can teach you about medical, physiology, pathophysiology. You'll learn it. You'll learn it, I promise you. But the soft skills are very difficult. So I would say, as you go through this process, you know what the prerequisites are for med school, for NP, for PA. You have to take those classes. Yes, of course. But, pepper them and lean into it with fun courses, like, take a yodeling class, sing, take an impromptu, whatever, acting class, because those are the things that really drive how you'll know how to sit in an interview and impromptu it. You'll know how to be able to, whether that's PA school interviews, whether that's your job interview, first time out of PA school, those are things that make weird connections that you never realize are going to happen when you're in an interview space. I mean, you're like, a candidate with, I don't know, 1,000 other people, and you've all taken hard science classes. You all have these GPA, but what's going to, make you different? It's the interpersonal thing. And so to me, if I had to do it all over again, I'd just do the same thing, because I did a lot of different, I was a phlebotomist, I was a PT aide, I TA'd for anatomy, I TA'd for psychology. During this period of time, I worked at a mortgage company, I was at Arby's, wide enough range that now when I talk to patients and I'm obtaining a social history, I'm like, oh yeah, hey, I did that for a time. And then you're just kind of shooting the stuff while you're doing an exam, and it builds rapport, it builds trust, it builds credibility. You're going to learn all the other stuff. You have your whole profession and life ahead of you. But what's tough is learning how to make connections. That's really tough. And I would say, going out the door, to answer that question, what would I propose to you? Yeah, take your prerequisite classes, get in there, dig in deep, but take some time for you and to learn who you are and to learn how people tick. I think that's probably the most important thing, is to lean into your general eds, but choose your general eds wisely. They ask you to take this and that and the other, but you get to choose from a range. Do it and lean into it.
Yeah, that is so insightful. That speaks volumes, because this reminds me of one saying. I'm pretty sure a lot of people have heard of it. How when you leave an interview, that interviewer is not left with the words that you say, but how you made them feel. And those interpersonal skills, I mean, that's the key to unlock that, to make an enjoyable time, have a conversation. It's not all formal. So I'm sure a lot of students can take that, hopefully use it towards what they might have in the future with interviews. Some might be in the application cycle right now. So definitely something to leverage. I really appreciate that.
Of course. Thank you. Thank you again.
Absolutely. I do have some reminders to wrap up for those who are listening in. So we do have a quiz at the end of each of these sessions. That quiz is just 10 questions. You must pass or have 6 of those questions correct in order for you to pass and receive a certificate. That certificate will be sent to the email inbox of the address that you list on the quiz. So be sure it's one that you're comfortable with. We recommend a personal email. So just keep that in mind, a Yahoo Gmail account, something like that. And it will be due next week on Wednesday, December 7th at 11:59 p.m. Central Standard Time. It's now posted in the chat box. So that's either to the right or the bottom of the live stream that you're watching right now. It's also available on our website on the virtual shouting page. There's 2 quizzes, 2 boxes for quizzes for our sessions, because we typically have 2 sessions a week. So scroll down a little on the page. You'll see a Monday quiz. You'll see a Thursday quiz. Click on the Thursday quiz and you'll be directed to that Google form. Like I said, 6 out of 10 questions or more in order to pass. And if you have any questions for us, feel free to shoot us an email. Again, it's shadowing.h4h@gmail.com. That's our address, and we can definitely get back to you to address any questions. Please do check your spam folder just in case if you don't find the certificate. But like I said, we are always happy to help if you need to retrieve your certificate after not finding it in the inbox or spam folders. And we will actually have another shadowing session tomorrow with Dr. Judy. She is a pediatric dentist. So our pre-dental students out there, we have a session for you. We'll see her tomorrow at 7 p.m. Central, so the normal time. And we will continue with more sessions next week. I really appreciate you, Viet, for joining in. For those who would like to get in contact with him or just hear more from him, he has his Twitter page, which he included on that last slide. So feel free to scroll back on that. But yeah, hope everyone has a great